Thank you all for joining us this afternoon for a very exciting topic of discussing the management of toxicities associated with immunotherapy. This is certainly a very exciting time in oncology in general, so I look forward to sharing with you some of the experience we've had at Milo Cancer Hospital and throughout our health network. So our objectives, as were highlighted earlier, are that we are going to identify the most common adverse events for immunotherapies, particularly in kidney cancer, melanoma, and lung cancer, and review the recommended management approach for each. We'll talk about factors that might either increase the risk for immune-mediated toxicities in patients being treated with cancer immunotherapies and the appropriate monitoring approaches. And then specifically talk about the signs and symptoms that patients need to be aware of to facilitate detection of immune-related adverse events. So let's just go through a quick overview. The purpose of our talk is to talk about the side effects, but it is important just to highlight the mechanism of action of immune checkpoint inhibitors, just to give us a foundation for how side effects develop. So the goal of immune checkpoint inhibitors are to help the immune system correctly identify and destroy tumor cells. The immune system does have several checkpoints for maintaining self-tolerance and minimizing damage to healthy tissue. The ones that will have approved drugs currently target the PD-1 and PD-2 as well as the PDL pathway and CTLA-4. The ligand receptors that are involved with the programmed death 1 and 2 pathways limit T-cell activity at the time of an inflammatory response, and CTLA-4 counteracts the activity of T-cell co-stimulatory receptor CD28. We do know that while these checkpoints are in place to help maintain self-tolerance, tumors do have the ability to evade the immune system by exploiting these checkpoints, and so it reduces anti-tumor immune response, which should be in place. And so that really becomes the target for us in terms of how these checkpoint inhibitors work. So one of the first things to consider when a patient is going to be started on a checkpoint inhibitor is a thorough pre-treatment evaluation. In general, identifying a patient who would be appropriate to start might include patients with a good performance status in some cases. So in some of the approvals, this does come into play, while it's either a certain disease state or dependent on the line of therapy in which the checkpoint inhibitor is going to be utilized. It is important to assess patients for a history of autoimmune diseases prior to the start of therapy, and we've listed several of those here for you to look at. We do know that on the clinical trials that led to the approval of these agents, patients in general that had autoimmune diseases were excluded from participating in the trials. So there is, at this point, some limited data on the use of checkpoint inhibitors in patients that have autoimmune diseases, but one does have to have caution that there is a risk of causing an exacerbation of any of these autoimmune diseases, which could become uncontrolled if a patient is started on a checkpoint inhibitor and that immune system is unleashed. Also important to screen patients for a history of chronic immune suppression. So for patients, for instance, that are had organ transplantation, that are on chronic immune suppression, we do not have data at this time to really demonstrate what the effect of either effect or the risks of treating patients that are on these suppressant agents. Also important to assess for prior end organ damage or compromise. So if a patient does have a long-standing liver dysfunction or renal failure, there may certainly be risks in the start of an immune therapy in causing perhaps an exacerbation or worsening and perhaps even life-threatening complications if they have prior organ damage. And of course, as all of us as healthcare professionals, our first goal when we're considering patients is to first do no harm before making that selection. I will just, in addition to the pre-evaluation, one needs to undergo a full medication reconciliation. In addition to prescription medications, one should certainly consider asking patients if they are taking any over-the-counter medications, particularly herbal and naturopathic supplements. Many of these supplements are not regulated by the FDA, and there is not guaranteed review of the components of the supplements. So specifically, we should be asking patients if they're taking any immune boosters. Particularly, several of these are available through mail-order catalogs, and so important to ask patients if that is indeed something they're taking. In addition, being fairly clear of whether or not the patient is already on current doses of steroids for any particular ailment that they might have. Prior to the start, also important to understand a patient's baseline symptoms. Having a thorough understanding of the patient's baseline review of symptoms will really serve as your foundation for evaluating both response to therapy and potential adverse side effects that the patients might have. One should start a patient with baseline laboratory evaluation as well, including a complete blood count, comprehensive metabolic panel, as well as thyroid function tests to help rule out any underlying organ dysfunction. And, of course, a thorough physical examination to provide your foundation to assess for any changes in status while patients are on therapy. So this slide is an overview of what the current approvals are for the checkpoint inhibitors that we have now. The first one, an anti-CTLA-4 agent, the ipilimumab, is approved currently in two different dosing regimens, the first 3 milligrams per kg over 90 minutes every 3 weeks times 4 doses, and that is for patients with unresectable or metastatic melanoma. The next dosing is 10 mg per kg IV over 90 minutes every 3 weeks times 4, and then administered every 12 weeks. And that's approved for delivery in patients that are receiving adjuvant treatment for stage 3 melanoma. Nivolumab was the next, and that is an anti-PD-1 agent. There are two different dosing schedules for this as well. There's a fixed dosing of 240 milligrams IV over 60 minutes every 2 weeks, and that dosing regimen applies to unresectable or metastatic melanoma, metastatic non-small cell lung cancer, and advanced renal cell carcinoma. The other dosing schedule is 3 milligrams per kg every 2 weeks, and that is particularly for classical Hodgkin's lymphoma and recurrent or metastatic head and neck squamous cell carcinoma. Pembrolizumab, also an anti-PD-1 agent, is 2 milligrams per kilogram every 3 weeks for melanoma, and a fixed dosing of 200 milligrams IV over 30 minutes every 3 weeks for non-small cell lung cancer. And you can take a look at the two different approvals for non-small cell lung cancer. First-line setting is approved if the tumor proportion score of the patient, so if they have PD-L1 testing done and it's greater than 50% and they do not have an EGFR or an ALK mutation, patients can receive pembrolizumab in the first-line setting. It's also approved in the second-line setting if the TPS score is at least greater than or equal to 1% by standard measurements. So first, the second-line setting, patients can have received a platinum-based regimen, or if they had an EGFR ALK mutation, they could have received those targeted therapies to go on to the second-line setting. And it's also approved for recurrent or metastatic head and neck squamous cell carcinoma. Atezolizumab, a slightly different target, which is the PD-L1 target, is approved at 1,200 milligrams IV over 60 minutes every 3 weeks, and that's approved for locally advanced or metastatic urothelial carcinoma as well as metastatic non-small cell lung cancer. When we begin to look at the toxicities, this is just really to give you a snapshot of the types of toxicities that we do see, and then we're going to go through each organ system in particular. If one looks at ipilimumab, the two dosing schedules of 3 mg per kg and 10 mg per kg, one can see that there is some variability in terms of pneumonitis, colitis, rash, and pruritus. One of the things that is rather challenging for us when we're looking at some of the toxicities between the agents is that several of the different trials really categorize toxicity slightly differently and use different terminology. So we really need to do an analysis of several different terms as we're looking through these studies and going through the data so that we can really be able to appropriately interpret the overall frequency of the AEs that we do see. And this data is all pulled from the prescribing information for each of these drugs. You can see that there is a slightly increase risk of developing enterocolitis and dermatitis in the combination arm of the ipilimumab and nivolumab arm in this particular chart. So now let's go on again to, what is the basis of the side effects? As I mentioned before, immune checkpoint inhibitors promote T-cell activity. Activation, however, of the immune system cannot be confined to anti-tumor effects. Immune checkpoint inhibitors are associated with what we call either immune-related adverse events or immune-mediated adverse events. So you might see both of those terminologies in the literature. Immune checkpoint inhibitors promote T-cell proliferation, allowing the immune system to recognize tumor antigens. However, if the T-cells become overactive, they will start to attack healthy tissue, and this process is referred to as autoimmunity. This process can occur in any organ of the body, and it typically occurs in systems that have organ systems that contain significant T-cells. There are variabilities in the patterns of these immune-related adverse events, and this is slightly different than what we might see in our cytotoxic or targeted therapies. They are typically low grade, but as we will go through, we will see that any grade toxicity can be seen. So median time to onset is about 5 to 12 weeks after the initiation of therapy. However, we still can see some toxicities develop within days of the first dose, after several months of treatment, or even after the discontinuation of therapy. And there have been some documented AEs that have occurred even a year after patients have continued therapy. It may affect one or many organ systems, and that may either occur sequentially or concurrently, and there's not a way at this time to predict what that pattern is going to be. As I said, the severity can be asymptomatic to severe and life-threatening. There is some suggestion that there's a dose dependency and even a cumulative effect. And there may be an increase in toxicity associated with combination of other immune therapy agents, chemotherapy, radiation therapy, and I should say targeted therapy here as well, as we begin to see many of these trials roll out. So this slide is a bit busy, and it's not meant for you to memorize everything on it. The point really here is to say that immune-related adverse events can affect many organ systems and manifest in many different ways. As I mentioned, it may occur in one or multiple organ systems. We're not able at this time to predict the organs that will be affected or the onset, timing of onset, or whether they'll be concurrent or sequential. So all of us as healthcare providers need to make sure that we're alert to any changes in any of these organ systems throughout the course of a patient's therapy. So now we're going to break this down and really go through kind of a step approach to how we're going to assess patients. Really the key to assessment for patients is to have a systematic approach to monitoring the organ systems and also grading for potential toxicities. We typically use the CTCAE criteria for evaluating toxicities, and you can certainly download that and get an app for that to make it easier for you in your clinical practices, and that is online through the National Cancer Institute. When we look at pulmonary toxicity, this typical onset for adverse event can occur 2 days through the duration of treatment. Grade 1, patients are asymptomatic, so they may have clinical or diagnostic observations only. Grade 2 toxicity is mild to moderate symptoms, and it may limit some of their instrumental ADLs. Medical intervention is typically indicated at grade 2. Grade 3 and 4, patients demonstrate severe symptoms limiting self-care ADLs. They also may have new or worsening hypoxia and can have life-threatening variability as far as their respiratory status and even acute respiratory distress in which urgent intervention is required. So having a step approach, it's important to understand, as I said, the patient's current baseline symptoms. As I said, the onset of the symptoms can develop 2 days throughout the therapy. Patients may report dyspnea, dry cough, wheezing. They may have tachypnea, tachycardia, shortness of breath at rest, may note some hypoxia or an increase in oxygen requirements. If it is more progressed, they may even have chest pain, or as stated before in earlier stages, radiographic changes. Typically, the recommendation is to have monitoring of the patient's oxygen saturation. In my practice, what our recommendation is that we have a resting baseline oxygen saturation and then also obtain oxygen saturation having the patients ambulate several yards to see if there's any difference in this. And this is oftentimes the most useful tool in identifying an early onset of a pneumonitis or any change in respiratory status. The first thing to do when a patient has these symptoms, typically we worry about whether or not they have progression of disease. We want to rule out any other infectious cause, rule out lymphangitic spread, and rule out pulmonary embolus or even pleural effusion from the pulmonary status. This can be a bit challenging, particularly in the patients with any kind of lung cancer, small cell lung cancer, non-small cell lung cancer, or patients have a lot of bulky pulmonary disease. This can be a bit challenging. For grade 1 toxicity, so patients that have radiographic changes or some clinical signs that you're finding, typically monitoring every 2 to 3 days is the recommendation. I will say that there is some variability across practices that I've gone to visit in terms of following these, but it really is important to be able to understand if patients are having changes in their respiratory status on a more frequent basis. If they do develop a grade 2 to 4 toxicity, daily monitoring is recommended. So one needs to consider, in terms of other causes, participating with our colleagues as far as consults. So a pulmonary consult, perhaps interventional pulmonary to assist, infectious disease consult, and typically the classic scanning for evaluation for patients is going to be a CT scan. Very rarely are you going to be able to pick up some subtle changes on a chest X-ray alone, unless it's really a very classic progression. A bronchoscopy may be necessary as well if one's trying to rule out whether or not there is an infectious process going on or if indeed this is pneumonitis that has developed. So for management, grade 1, consider withholding the checkpoint therapy until the patient's symptoms resolve. And again, that's just a consideration. For grade 2, which is mild to moderate worsening from baseline, you want to withhold the checkpoint therapy and in most cases administer steroids at 1 to 2 milligrams per kilogram per day of prednisone, whether that's IV or an oral equivalent. Typically, grade 2 can be monitored on the outpatient basis if their patient is hemodynamically stable. For grade 3 or 4 toxicity where they have severe symptoms, new or worsening hypoxia, steroid dosing may need to typically be increased to 2 to 4 milligrams per kilogram per day, and they need to maintain that until their symptoms have stabilized and returned to grade 1, and then you will taper off the prednisone slowly, and we'll go over that strategy when we get to the end of the presentation. Patients typically require oxygen support as well as an albuterol nebulizer or IV steroids. So let's take another case. This is a patient, SG, a 58-year-old male with non-small cell lung cancer. This patient received concurrent CTLA-4 agent and anti-PD-1 agent. That they received 3 cycles and initially presented with sinusitis, went to their primary care physician, and was put on antibiotics. And we'll talk about that first little glitch in that patient's monitoring to begin with. They then came in for cycle number 4 of treatment, complaining of cough, chest tightness, shortness of breath. Their oxygen saturation, when we had started this person's treatment, had been 98%, and now they were coming in and their oxygen saturation was decreasing to 84% with ambulation. As I mentioned initially, chest X-rays are usually not the first line of treatment of evaluation. However, a chest X-ray was done that did indicate new infiltrates in the left upper lobe. Consider which of the following would be most appropriate steps for this patient: administer oxygen, obtain a CT angio of the chest, do a bronchoscopy, start to administer IV methylprednisolone, hold the nivolumab and ipilimumab, or all of the above. The correct answer for this question is all of the above. So this patient clearly is in need of additional oxygen. CT scan, as I mentioned before, is really the test that's going to help delineate much more clearly if there's a pneumonitis process going on. Because the patient had an infectious process going on, it was also recommended that they undergo a bronchoscopy to really help delineate whether or not there were 2 processes going on. IV methylprednisolone was initiated, and certainly because of this grade 3 toxicity for this patient, the nivolumab and ipilimumab were held. So going on, the CT angiograph did demonstrate new ground glass opacity and pneumonitis. The patient was admitted to the hospital, and as I stated, they did receive the methylprednisolone. Treatment was held. The bronchoscopy, unfortunately, also indicated infiltrative pneumonitis. Once the patient was stabilized, they were discharged to home on a prednisone taper, and they were also administered prophylactic antibiotics to prevent any opportunistic infections for when patients are on long-term steroid tapers. So now we'll move on to dermatologic toxicity. Dermatologic toxicities are variable across the agents that we pointed out, as you saw with the first chart of toxicities, but the onset can be from 1 day to 25 months or even post-treatment. When we're grading dermatologic toxicities, particularly with rash is grade 1 or 2 if it's covering less than 30% of the body surface area. So grade 1 is less than or equal to 10%. Grade 2 is less than or equal to the 30%. And this may or may not be associated with symptoms of pruritus. Grade 3 and 4 toxicity covers greater than 30% of the body surface area. Again, may have additional symptoms, but there is also a limitation in self-care and may even be life-threatening consequences associated with this. So patients may develop a variety of different dermatologic side effects, adverse events, not limited just to rash. They may develop pruritus just on its own, other forms of dermatitis, vitiligo, lichenoid implants. If it does progress, patients may even develop some peeling or blistering of the skin, and occasionally patients have developed some oral ulcerations as well. Obviously, in very worst cases, grade 4, patients can develop a Stevens-Johnson syndrome if this is not intervened with and appropriately managed. The key for any of these rashes or new dermatitis-type flares is to rule out other causes. Is there a cellulitis? Is there contact dermatitis? Has there been any other drug exposure that may have triggered a reaction? Has the patient been in the sun? So is there a sun kind of radiation recall or activation? Typically, for evaluation, if symptoms persist for more than 1 to 2 weeks or recur, dermatologic evaluation is going to be recommended, and patients may also require a skin biopsy. So as stated before, the grade 1 to 2 toxicity is less than 30% of the body surface area covered. Treatment recommendations are topical steroids, anti-itch creams. If the rash does persist for more than a week or interferes with activities of daily living, may need to start a moderate potency steroid cream, so really kind of increasing the approach. For grade 3 to 4 for skin toxicity, so greater than 30%, if there is serious desquamation, the checkpoint inhibitor should be discontinued, and patients should be managed on IV steroids. Once they get to be a grade 1, once it's improved to a grade 1, then these patients can begin to taper off on their steroids. Additional supportive medications may be necessary, particularly for the pruritus, so antihistamines may be of benefit for patients. Gastrointestinal toxicities are also rather common, and it's really important to help identify not just whether or not a patient has diarrhea, but also if they have any other symptoms of colitis. So the onset can be 3 days to 10 weeks or after several months of therapy. We do see the onset of this a little bit earlier on in combination therapy. Grade 1 is less than 4 stools per day over baseline. These patients tend to be asymptomatic. Grade 2 is 4 to 6 stools over baseline. IV fluids may be indicated. Patients with colitis may develop also with abdominal pain, blood in the stool, cramping, flatus. There is typically at grade 2 no ADL interference. Grade 3 is greater than 7 stools per day over baseline. IV fluids are required. It does interfere with ADLs. Patients may have severe abdominal pain, peritoneal signs. Medical intervention is indicated. And grade 4 can be life-threatening, and patients can develop a perforation if this is not managed earlier on. I just want to point out one thing when we talk about the gastrointestinal and the risk for colitis. It is important to be looking at the signs and symptoms as well as the number of stools a patient have. Patients can develop a colitis with abdominal pain, cramping, without having the diarrhea. So you want to make sure that you're evaluating them for the potential colitis, even if they don't have a significant increase in the number of stools over their baseline. So, as I said, 3 days to 10 weeks, abdominal pain, cramping, change in bowel habits. Take into consideration patients that do have ostomies, so you want to be looking at ostomy output by volume. Look for mucus or blood in the stool or incontinence. For perforation, take into consideration peritoneal signs, whether the patients have developed sepsis or an ileus. So calculating frequency and volume of stool and diarrhea is important. You do want to rule out other causes, particularly infectious causes such as C. difficile, particularly in patients who may have been in the hospital recently or been on long-term antibiotics. It can be helpful initially to obtain a stool for white blood cells. That will help you to rule out whether there's an infectious process going on. Also important to get a stool for CNS C. diff level. Other GI toxicities that can occur are pancreatitis as well. So if somebody does have vague abdominal pain or discomfort, it's important to have a baseline level of an amylase and lipase and then to be monitoring those. Patients may require abdominal ultrasound or an abdominal CAT scan, and certainly consultation with a gastroenterologist is valuable. Patients may or may not require an endoscopy or colonoscopy. If they do have a grade 1 toxicity, we would continue checkpoint therapy. For grade 2, withhold the treatment until the patient's symptoms return to a grade 1. Discontinue the checkpoint inhibitor if there is recurrence or if the symptoms are lasting more than 5 days, and then steroids would be initiated at grade 2. For grade 3, for the diarrhea, you withhold the treatment and initiate steroids. If a patient does return to a grade 1, you can consider restarting the checkpoint inhibitor. If they have a grade 4 toxicity, that is foundation for permanent discontinuation. Supportive care measures include hydration, dietary changes, antiemetics, antidiarrheals, and antispasmodics as necessary. If the patients are refractory to the steroid therapy, you may need to initiate a second immune suppressant agent, and that the recommendation is for infliximab as long as it's not contraindicated in patients. Now we'll move to the endocrinopathies, which can occur, and these are really a class-specific type of adverse event that does occur or may occur. Typical onset is 4 to 20 weeks. Oftentimes patients are asymptomatic. Typically, the pattern of how this develops is patients develop a transient hyperthyroidism and then followed by hypothyroidism. Patients should have a baseline TSH level, free T4 level, and a T3 level obtained. In most cases, if patients develop hyperthyroidism, as I mentioned, are asymptomatic. But if it does become more significant, they may have weight loss, irritability, palpitations, diarrhea, or flushing and feeling hot. In most cases, we withhold the therapy until they're a grade 1, manage the symptoms. Antithyroid medication of methimazole may be required. Beta blockers are often prescribed for palpitations. When symptoms are under control, we can consider reinitiating the therapy. In most cases, however, with hyperthyroid, in short order, the patients then have their thyroid really is burned out and become hypothyroid. These patients come into the office with feelings of fatigue, sluggishness, anorexia, weight gain, dry skin, constipation. In general, the treatment of choice is to withhold therapy until their symptoms are controlled with the initiation of levothyroxine. You want to start out at a lower dose, particularly in elderly patients who might have a pre-existing cardiac disease, and then slowly titrate up the dosing of the levothyroxine, adjusting to maintain the free T4 level in the mid-range. And when their symptoms are under control, as I mentioned, the checkpoint inhibitor can be restarted. Typically, this is going to be a lifetime requirement because thyroid function does not typically return even after the patient has been discontinued on the checkpoint inhibitor. The other two endocrinopathies that can develop are hypophysitis and adrenalitis. So hypophysitis, an inflammation of the pituitary gland, can lead to visual disturbances, headaches, fatigue, weakness, confusion, hallucinations, memory loss. In general, when these patients do come in with these symptoms, our first concern typically is whether or not they have brain metastases. So obtaining an MRI of the brain is really crucial. And in ordering so, one needs to certainly indicate that you're evaluating for hypophysitis so that there can be pituitary cuts in that MRI to help you better delineate what is actually occurring. Also, hormone levels should be obtained, such as the ACTH, FSH, luteinizing hormone, ADH as well. Endocrine consult is recommended at this point because these patients can develop long-term complications if this isn't managed. Stress doses of IV steroids with mineral corticoid replacement if they are in adrenal crisis is recommended. Adrenalitis or an inflammation of the adrenal gland can lead to adrenal insufficiency and crisis if it is not managed. These patients also present with vague fatigue, malaise, perhaps hypotension, and vague GI symptoms in general. Important to obtain a morning cortisol level, ACTH level, and we've got the parameters here for what you would look for the AM cortisol level. Patients that develop an adrenalitis or adrenal insufficiency, this may be permanent, and they may require lifetime hormone replacement, with a particular consideration that they might need stress dosing of steroids if they undergo additional procedures such as surgeries in the future because they will not have that adrenal response to stressors. And just to take into consideration that they might also require hospitalization and management initially. Renal dysfunction can occur at days to months. One wants to monitor blood creatinine level if there's an increase of 0.3 over their baseline, or if the creatinine is 1.5 to 2 times above baseline. Grade 2 is a creatinine of 2 to 3 times above baseline. Grade 3 is greater than 3 times over baseline, or if the creatinine level is 4, and then grade 4 is life-threatening. Often, in most cases, renal toxicity tends to be what I would call a paper toxicity. In most cases, patients are not symptomatic, and we're typically just looking at these elevations on their blood panel when they do come back. If it does advance, they may develop some vague symptoms of nausea, emesis, decreased urine output, and even some blood in the urine, but most of the time we identify it before then. So again, serum creatinine and urinalysis are helpful. If they do develop an acute renal injury, nephrology consult is recommended, and patients may undergo renal ultrasound and indeed a biopsy just to confirm that this is not a secondary process. You want to take into consideration if they're on any other renal toxic drugs, so doing that medication reconciliation is going to be critical, and limit nephrotoxic medications and antibiotics. Provide hydration. If they are grade 1, continue treatment. Grade 2 to 3 would be withholding treatment, monitoring their serum creatinine every 2 to 3 days. If you're initiating steroids, that would be 0.5 to 1 milligram per kilogram per day of prednisone equivalent. If there is no improvement, you need to increase that to 1 to 2 milligrams per kilogram per day. And with grade 4 toxicity, there is permanently discontinuation of the treatment and initiation of the steroid. Hepatic or liver adverse events can develop at 9 days to several months, and we've got our parameters here for our transaminases. So one may see an elevation of AST or ALT independent of whether or not there's any change in the bilirubin. So you want to grade the toxicity based on AST and ALT and also with the total bilirubin. So grade 1 is up to 3 times the upper limit of normal. Grade 2 is 3 to 5 times the upper limit of normal. And grade 3 to 4 is 5 times the upper limit of normal. As I mentioned with renal, this is oftentimes a paper toxicity as well. Patients typically are asymptomatic here. However, they may develop some nausea, fever, vague abdominal discomfort, right upper quadrant pain, and certainly if it progresses, could develop some jaundice. Liver enzymes to monitor AST, ALT, ALK, total and direct bilirubin every 3 days until their toxicity is resolving. They may require liver ultrasound and consultation with gastroenterology for further evaluation. Management, again, screening for any hepatotoxic drugs, particularly acetaminophen and over-the-counter medications as well, and herbal medications. to assure that they are not on any hepatotoxic contraindicated medications. Grade 1, toxicity, hepatic toxicity, we would continue on with treatment. Grade 2, withhold treatment, administer prednisone 0.5 to 1 milligram per kilogram per day. And if they respond to a grade 1, you can assume that you can resume the therapy when the steroid is tapered. Grade 3 to 4, permanent discontinuation and the start of steroids. If the patient is not responsive to the prednisone initially, and the IV prednisone may need to add another immune suppressant agent, and with hepatic toxicity, the recommended treatment is going to be mycophenolate. For neurologic toxicity, these are quite rare, but they can occur at 2 to 8 months after. Patients are asymptomatic in early stages, but grade 2, they may have some symptoms that do interfere with their instrumental ADLs. Grade 3 to 4 toxicity is new onset of severe symptoms, limiting their self-care, as well as some life-threatening complications. As far as the evaluation, patients may say that they have some unusual weakness, numbness, difficulty walking, ambulating, performing ADLs, some headaches and confusion, some memory difficulties. Again, with neurologic, the first key is that you want to do the MRI of the brain to rule out whether or not there is new brain metastases or whether the patient's had a CVA. So again, ruling out other causes in addition to infection before one makes the assumption that this can be assigned as an immune-related event. And then to certainly consult with neurology for a continued evaluation. For grade 1 toxicity, we continue on with therapy. For grade 2, again, steroid initiation, and once the patient is down to a grade 1, you can restart again. Grade 3 and 4 is permanently discontinuation of treatment. Ocular toxicities can develop days to months. Patients may be asymptomatic or have very mild symptoms. Grade 2, they may develop symptoms limiting some of their ADLs or develop an anterior uveitis. Grade 3, symptoms are limiting self-care, and this extends to a posterior or pan-uveitis. Grade 4 toxicity can lead to perforation or blindness. Typically, patients usually is more lower grade. Patients may have painful, itchy, watery eyes, decreased some visual acuity. Dry eyes is very common, or injected, you may see injected conjunctiva. In most causes, you want to rule out other infectious causes for evaluation, also to rule out any other ophthalmologic types of injury that the patient may have had. So ophthalmology consult is going to be quite valuable. Typically at grade 1, just a lubricating eye drops are all that is required. If they do have grade 2 toxicity, may need to have a corticosteroid eye drops and may consider holding therapy. If they do develop a grade 3, so really significant, unresponsive to topicals, they may require prednisone at the 0.5 to 1 milligram per kilogram per day until it decreases to grade 1. If there is grade 4, there is permanent discontinuation of the therapy and continued steroid use. Cardiac toxicity includes pericarditis or any inflammation of the heart. This can occur at days to months or even after treatment completion. In general, patients are asymptomatic or they may have just some subtle EKG changes or physical findings on exam such as a rub. Grade 2 is symptomatic pericarditis, so they say they might develop some chest pain. And then grade 3 is symptomatic pericarditis with physiologic consequences and even pain at rest. And grade 4 is going to be life-threatening complications. So, again, we've talked about the symptoms. Patients may also report dyspnea, have fluid retention. Evaluation for these patients includes an EKG, an echocardiogram, and certainly a cardiology consult. For grade 1, we hold treatment. Grade 2, hold treatment and medical intervention as necessary to maintain cardiac functioning, as well as the initiation of steroids. And grade 3 and 4 will be grounds for permanent discontinuation of therapy and the initiation of IV steroids with methylprednisolone. So in general, we've gone through several of the organ systems, but I just wanted to summarize for you that it is helpful to have an algorithm for the management of immune-mediated or immune-related adverse events. And so this really summarizes for us how we manage. So for grade 1 toxicities, patients are asymptomatic, diagnostic changes only. We continue on with immune therapy. Grade 2 with mild to moderate symptoms, we initiate, hold treatment, provide supportive care. If necessary, start steroids. If they improve and you can transition them to oral steroids, the suggested dose when they go from IV to oral is to transition to 60 milligrams of prednisone daily for 2 weeks and then begin to taper over a 4-week period of time until symptoms are resolved. You may reconsider reinitiation of immunotherapy. If, however, they are progressing or have recurrent grade 2 toxicity, you want to treat them as a grade 3 to 4. Certainly working with our colleagues for multidisciplinary evaluation of the toxicity. Grade 3 and 4, in general, there is a discontinuation of immunotherapy, as I mentioned before, not in the case of the hypothyroid where the patients can receive thyroid repletion. Methylprednisolone may need to be increased. If patients are refractory, an additional immunosuppressant may be required, such as infliximab, mycophenolate, cyclosporin, or IVIG. What's really most important for patients that are on long-term steroids is that you need to, again, consider antibiotic, antimicrobial, antifungal prophylaxis to prevent opportunistic infections that may occur in these patients. This is just an example of how of algorithms that are available from several of the companies in their prescribing instructions. But this is really kind of just a step approach, and more several of the larger national organizations now are going to this kind of coding in the algorithm of using the green, the yellow, and the red in terms of the algorithm to follow for both assessment and management of these immune-mediated adverse events. So obviously grade 1, you're just going to continue on therapy, but use some caution. Grade 2, very cautionary in terms of monitoring the patient, and then grade 3, 4 toxicity is permanent discontinuation. So additional guidelines for steroid therapy. When used, it really is essential to taper over 30 days so that you don't so in the case of these patients that are on it for a long time, you want to prevent a flare or an exacerbation of their symptoms. Again, rapid taper may result in recurrence. Patients should be on a proton pump inhibitor for GI protection. I already mentioned antimicrobial, antifungal prophylaxis. And if they're going to be on long-term steroids, they should be receiving vitamin D and calcium supplements, so to prevent osteoporosis. Family and patient education is really critical for patients that are starting on these therapies. So educating them about time to response, that it differs from standard therapy, and that it is a different side effect profile. And so educating them about each of these potential toxicities is really essential for early recognition of the immune-mediated adverse events is essential to effective treatment. Also important, patients should notify all of you as their care provider if they develop any of these symptoms, or if they, for some reason, are admitted to another facility. Really important, too, that other healthcare providers are informed that they are on an immune checkpoint inhibitor, and so the management of the toxicity is going to be very different than if they were on another type of therapy. Special populations just to consider. It's not been studied in the checkpoint inhibitors, but one can make the assumption that antibodies are known to cross the placental barrier, and it can affect developing fetuses. So all checkpoint inhibitors approved to date are pregnancy category C, so use is not recommended, and patients should use appropriate contraception for 6 months after completion of therapy, and as well should avoid breastfeeding for at least that period of time when on therapy. The one thing I didn't mention as far as an adverse event is that there is a small percentage of patients that might develop an infusion or a site reaction across the various studies. Typically, these are low grade and managed with just slowing down the infusion rate. But if obviously it is more life-threatening, then permanent discontinuation of therapy should be pursued. And again, pre-medication not required for infusion at all, particularly steroids. So if you've got pre-standing order sets, you want to make sure that that is removed from those. And so key points to management, just to sum this up, toxicities can be life-threatening if not managed promptly. Rapid diagnostic and treatment intervention is imperative for optimal control and prevention of end organ damage. Persistent grade 2 immune-mediated adverse events and grade 3 and 4 are treated with corticosteroids. It is very helpful to use some standardized algorithms for monitoring and for AE management as they can really help guide your practice. Early discontinuation of steroids may increase the risk of relapse, so tapering over the course of several weeks is recommended. And just to reassure patients that reinitiation of therapy may be possible with optimal management of these AEs. But just to say, not always very clear exactly when to restart treatment, so clinical judgment remains imperative in managing these patients on therapy.